All right, thank you to everyone who's already jumped on. We're going to give it a minute or so because we had a lot of registrants for this webinar, so we want to give everyone a minute to jump on. I know everyone's probably transitioning at the end of their workday if you're on Pacific time. I know for us East Coasters, um, it's a little bit later, but we're excited that everyone was able to make the time to join us. The numbers are steadily ticking up. So real quick, I just want to, again, thank everyone for joining us, thank our presenter, and just make a quick note that this webinar is hosted by the Gender and Sexuality Subcommittee of the DEI Committee of WDS. We received some questions during the registration process, but if you have any additional questions, feel free to use the Q&A feature. We will leave time at the end to answer those questions. This will also, and it is being recorded, so it will be available if you're for any reason. It'll be available and we'll share it out in the newsletter. If you are not currently a member of WGS, please take a moment to check out our website, womensderm.org. Consider becoming a member, and you'll have access to more exclusive content in the future. As of now, we are at 53 attendees. It's fantastic. I'm glad everyone has made the time. And I'm going to go ahead and pass it over now to Dr. Kraus, who is the lead of the Gender and Sexuality Subcommittee of the DEI Committee, and she'll take it from here. Again, any questions, feel free to put them in the Q&A, or just comments, feel free to put them in the chat. And thanks again for being here.
Thank you so much, Jess. All right. So on behalf of the WDS DEI Committee, I am thrilled to introduce our speaker for this session, Dr. Markus Boos, who is a pediatric dermatologist at Seattle Children's Hospital and an associate professor in the Department of Pediatrics at the University of Washington School of Medicine. He is also the program director for the dermatology residency. Dr. Boos was raised in the suburbs of Detroit and received a BA in biology and economics from Kalamazoo College. He then joined the medical scientist training program at the University of Chicago, where he obtained his MD and a PhD in immunology. He completed an internship in pediatrics at the University of Chicago's Children's Hospital before he joined UPenn as a dermatology resident, where he then served as chief resident, finally before completing a fellowship in pediatric dermatology at the Children's Hospital of Philadelphia. Dr. Boos enjoys caring for all children with skin disorders, but has a special interest in LGBTQIA2S+ health, which is what we're going to hear a little bit about tonight. The effects of climate change, including wildfires on the skin, and the cutaneous manifestations of primary immunodeficiency disorders. Dr. Boos has numerous publications, is a fantastic speaker, and also one of the most approachable and kind people you will ever meet. So with that, I'm going to hand it over to Dr. Boos.
Thank you, Dr. Krause. I appreciate that introduction. It was very kind. You're going to make me blush before I even start. So yeah, I will be speaking with everyone. Thank you all for being here. I appreciate the invitation and just the enthusiastic number of participants too. And what I'll be speaking with you today about is caring for sexual and gender minority children in the dermatology clinic. And the majority of my talk will be focusing on transgender and gender diverse children specifically. And for those of you who only see adults, there will be plenty of tips for you as well. But want to make sure we're taking some time to think about extra considerations that are specific to the care of children. So let me share my slides. Okay. Are we seeing my slides correctly?
Yes.
Okay, great. All right. So I do have one disclosure to make. I do some work with Regeneron for their dupilumab trials in atopic dermatitis. I do not get any money from them. It just goes to our institution. I also want to give a huge shout out to the SPD, the Society for Pediatric Dermatology, and the Pediatric Dermatology Research Alliance. These two organizations have been fundamental in my career and just allowing me to follow a path that interested me and supporting me in caring for children, which I love. One of the big things that they did for me, though, that I have to give a shout out to is I was awarded a mentorship grant to work with this guy, Dr. Robert Sidbury. For those of you who knew him, he was an amazing physician and leader. He unfortunately passed away unexpectedly last July. Still kind of working through that. So if I get a little bit, choked up, you'll have to forgive me. But he really just had a profound influence on my life and my career, and specifically giving me sort of the permission and the encouragement to become a doctor who really cared for queer kids. And I wouldn't be here today without him. So I wanted to shout him out as well. I do have one other disclosure to tell you, and that is that I am gay. And, when I think about like why I need to share this with you, it's because this topic is very personal for me. I am not transgender. I am not gender diverse. I don't, profess to know what it's like to exist as a transgender or gender diverse person. But it's the LGBTQ community for a reason. This is my community and something that I feel really strongly that, it's a group of people that I want to support to make sure that they're getting equitable and thoughtful care. And, this whole work just has a lot of meaning for me. So our objectives today, I hope to improve your understanding of the social forces that impact our patients' lives, and then also our role as dermatologists. Improve the understanding of healthcare disparities that uniquely or disproportionately affect sexual and gender minority individuals, and then provide an overview on how to approach sexual and gender minority children in the clinical setting. Before I start, I guess I just want to talk a little bit. I appreciate having the opportunity to give this talk at this moment in time. Speaking about transgender and gender diverse patients, is not something that's without controversy in the world that we live in right now. And I don't intend on making this political, but I do need to just kind of say, my parents and I have sort of differing views on things. And they've often said to me, like, why does everything have to be so political for you? And my response to that is, I'm a gay man who cares for transgender children. It's not something that I see as political, but being politicized is something that is done to me. And so I can't exist in this space without sort of addressing it. And, I think my hope for all of us as we go through this next, half an hour to an hour together is that we just have an understanding and maybe getting back to our roots a little bit. When we took the Hippocratic Oath in medical school, we didn't say, oh, I want to take care of like this group of people. We said, we're going to take care of everyone. We were idealistic and, excited to just be caregivers for everyone. And I hope that, obviously with the group that I'm talking about today is the gender diverse community, transgender, queer folks. But that's a lesson that kind of goes back to all the communities that we might be able to and want to care for. My goal with this is to make this an inclusive space, to call people in. I will say there are folks on the, in certain spaces that demonize my community, make life harder for them. I don't appreciate that. I also have a hard time with people who may feel strongly about the same values that I have when we become really rigid on who is allowed to partake in caring for people. I think that there's lots of well-meaning people who want to do well, who want to care for, transgender, gender diverse children in a really thoughtful way, but sometimes feel a little bit unsure or a little bit confused or trying to figure out for themselves, like, how can I ask these questions while being sensitive to the needs? How do I not put my foot in my mouth? And sometimes when we're really over dogmatic about saying, if you don't do this right, then you don't get to be part of our community, that really doesn't do us a service. And so what I want everyone to know who's on this, webinar is to know that it's okay to make mistakes, right? We're all learning and we're all growing together. And I think that if you approach, your learning on this topic and your patients with positive intent, they're going to know. And so again, I really appreciate you being here, just so that we can learn some tools and some skills together that hopefully will improve the quality of life for all the people that you take care of, but specifically, the queer community. So why does this matter? I want to get back to equality versus equity. These are terms that I think that many of us have become more familiar with over the last, 5-10 years or so. But just so that we're all on the same page and have a common understanding, equality means everyone gets the same thing. And equity means everyone gets what they need to get to the same location. So to kind of put it in more simplistic terms, right? If two friends of mine and I were all running a marathon together, and Nike says, we're going to give you all, size 10 shoes. Well, that's really great if one of us has size 10 feet, but that's not going to be super helpful for those of us who don't, right? So that's equality. We're all getting the exact same thing. Equity is to say, hey, what's your shoe size? Let me give you that, and then let's have you run that marathon. Or, maybe there's somebody who, is wheelchair or uses a wheelchair. can we make the course amenable and accessible to them as well, right? This is helping people get to the endpoint. And so we're each different people. When you have a transgender or gender diverse identity, there's going to be other considerations that are important to your healthcare, but we still want people to get to the same place, which is excellent skincare and excellent overall health. So that's what we're going for here. So I did want to talk a little bit about, again, sort of touch on the current cultural zeitgeist. So this is a photo of Patrick McHenry. He was our Speaker pro temp of the House a few years ago after Kevin McCarthy was sort of ousted from that position. And what this is actually a doctored photo. So here he is speaking to, cameras, and someone actually put this like carton underneath his feet. And I don't know what that person's intention was, but what I presume that it was is to say like, oh, this guy is short, and sort of in an effort to demasculinize him, right? And it's very fascinating this, and there's a whole extra layer on top of it, because then someone else took this photo and said, this is also gender affirming care, by the way. And I think it's important for us to kind of take a step back a little bit and say like, what are we getting at here? And I think, especially in this day and age, there's lots going on about like masculinity and femininity and what is sort of like the standard. How should we be displaying that? What is the way for someone to be quote unquote masculine or be quote unquote feminine? And dermatology plays a huge role in that, right? Especially when we're thinking about, cosmetic procedures. But I think it begs the question, right? Like who decides? And then more than that, like who decides who gets access to those medical surgical interventions that allow folks to actually demonstrate these qualities of masculinity or femininity? And again, right, I think that we need to take a step back from this whole picture, because one thing that was, in the news not too long ago was, children are going off to school and then they're getting sex change surgeries and then they're coming back home a different gender entirely. Obviously, that's not true, right? But these are all sort of social constructs, things that are put out into, the community for us to question, like what is it that we're striving for and who gets access to it and who holds the power to control who gets that access or not. And so, going into that, digging into that a little bit more, we actually have some data on who is getting gender affirming care. And it's a little bit more, I think, nuanced than you might think. So this is a study from the JAMA Network Open, and it is a retrospective cross-sectional study that is looking at a claims database that said who is receiving gender-affirming surgical care. And this could be all sorts of things: top surgery, phalloplasty, medioidoplasty, vaginoplasty, cosmetic procedures, right? What was some sort of intervention that was done to, let someone have gender-affirming care? And so in this graph that you're seeing here on the left, this was looking at folks who had a gender diverse diagnosis and then also received a gender affirming surgical procedure. Okay. And in all adults, it ended up being a little bit over five individuals out of 100,000 people in the population were actually receiving a surgical procedure. In children, that was even less. So in kids aged 15 to 17, so late teenagers, it was around 2 per 100,000. In children 13 and 14, it was a fraction of like 1. And then there were no children 12 or under that received any sort of surgical gender affirming procedure. So again, this whole idea of, kids are just kind of like walking into a clinic and being just like teed up for surgery, like that's not happening. And this is a fraction of a percent of children are actually getting gender affirming procedures. Beyond that, it's also important to recognize that there are other populations who are getting a gender affirming procedure. So in this figure, what we're looking at is the proportion of breast reductions performed on males, and then it's divided into whether they're transgender, gender diverse, or cisgender. And you can see here, there were 636 total gender affirming like top surgeries in adults and 151 performed in minors. And what these boxes are showing is the percentage of folks who are cisgender in the dark sort of blue-gray, and then transgender or had a transgender-related diagnosis in the light blue. And again, and the adults on the left, 80% of breast reduction surgeries were in cisgender men, and only 20% were in transgender or gender-diverse men. In minors, it was even a higher proportional discrepancy. 96% of children or minors who were receiving breast reduction surgery were cisgender, and only 4% had a transgender related diagnosis. So again, what we're saying here is if you have gynecomastia for whatever reason, if you identify as a cisgender male, it's totally fine for you to get the procedure. But as soon as someone who has a transgender identity seeks it out, all of a sudden the goalposts are changed, right? And so it begs this question of like, why is it that we allow some people to have these types of surgeries, but we police and we gatekeep for another group of folks? And that's just something I think for all of us to ponder a little bit. Beyond surgical care, I think it's also important to recognize how much sort of medical care is going on as well. So this was a similar study. This was published in JAMA Pediatrics, another cross-sectional retrospective claims database study. It involved over 5 million individuals and about 12 million people years. And what the authors of this study did was they looked to see from children who were like around puberty age until like through puberty until the age of 18, how many were actually receiving medical gender affirming therapy. So what you see in the green and the orange lines on the bottom is folks who were assigned male at birth or assigned female at birth and receiving puberty blockers. And on average across these groups, it was about 20 individuals per 100,000 were receiving a puberty blocker on average. In blue, what you see is the rate of individuals who are assigned female at birth but identified as a transgender boy or man receiving testosterone therapy. And then the sort of like grayish green line underneath that, those are individuals assigned male at birth that identified as a transgender female or woman, and they were receiving estrogen therapy. What you can see too here across all the age groups, it was about 50 individuals out of 100,000 were receiving testosterone. Once we get up to the 17 years, that spikes up to around like 100 or so. And for those receiving estrogen, it's about 25 on average. So even at its highest use, we're talking about a fraction of a percent of children are actually receiving gender-affirming hormones or puberty blockers to, help them with their transition. So this is not the sort of like rampant epidemic that it's made out to be. It's actually a small number of people who are receiving this care, from their either endocrinologist or their primary care or their gender care providers. But even though this is a small sort of population, it doesn't mean that it's not impactful, sort of what is happening in the world today. This is a study that was done. It was a survey study that was done a number of years ago in 2020, asking parents who cared for a transgender or gender diverse child, what do you think about all these bills that are being passed that are restricting access to care, for transgender kids? And what these parents relayed is that they had lots of worries. And one was they were worried about the safety of their child and potentially that the child would become suicidal. They were worried that their child was going to be discriminated against. They were worried that they weren't going to have access to the appropriate medical care that they were used to having, and that they were also going to lose their autonomy. These same authors actually presented this questionnaire to providers as well. And what the providers said was similar. They endorsed all the things that the parents were worried about, but they also said that they were worried that this politicized care, that they were asked to, obey standards that were actually not what was recommended by groups who study and make recommendations on gender care, and then that it also put them at risk as providers who are providing this care. So this whole discussion that we're having around gender affirming care is very, very meaningful to the folks who are experiencing the sort of loss of care or restrictions to care. And then the question is, how can we all step in to do our best to support this community? And it matters. And this is a study from Seattle Children's, my colleagues that are in the gender clinic here, and they actually looked at children who came through the gender clinic and how their mental health changed after receiving gender affirming care. And what they found is that the mental health outcomes in these children improved when they started receiving gender affirming care. And what they found is that, rates of depression, all these things went down. And that magnitude of improvement actually, was larger the earlier that children were able to start and access this care. So this is something that really, it has profound effects on an individual's quality of life, on something that I think that we should all recognize. This isn't doing something like just to do it, right? What we are doing is supporting someone in being who they are, and allowing them to have a better quality of life overall as a result of that. Let's talk a little bit about demographics, right? So like, what is the scope of the population that we're working with here? So this is some data from the Gallup polls, and what they are looking at here are adult American self-identification as LGBT. And what you can see is that this went up from around 3.5% in 2012 to 9.3% from the most recent data in 2024. And, the way that I sort of interpret this data is that as a whole and as a society, we have become more welcoming of people who identify as LGBT. And so people feel safe to come out. I don't think that's something kind of changed the last decade that all of a sudden there's twice as many, but rather we've created a social environment where people feel empowered and safe to, like be who they are. And that's really inspiring. The percentage of folks who identify specifically as transgender is around 1%, and that holds true, has been kind of holding steady and true across the duration of this polling. What about in kids? So, someone asked the question, are we actually underestimating the prevalence of gender diverse youth? And so this is a study that was done in Pittsburgh and the surrounding areas. And the authors of the study actually assessed gender diversity in a really novel way. So instead of just asking, sending out a survey being like, are you queer? Please tell us how. They actually had the children in this study, who are all high schoolers, answer two questions. The first question was, what does your birth certificate say that your sex is? And then they followed it up and they said, and how do you identify now? Cisgender boy, cisgender girl, transgender boy, transgender girl, genderqueer, something else. And basically they categorize people whose sex assigned at birth on their birth certificate. If that did not match with their, stated gender identity, then they classified them as gender diverse. And what they found from the study was that about 9.2% of children in the study population, identified as gender diverse in this way. And of course, the questions then came, hey, maybe this is social contagion. This is a big city. Maybe it's a liberal environment. Is this really true? The study authors then repeated the exact same study in rural Appalachia. And what they found there was that the percentage was 7.2. So I think that we are sort of underestimating to some degree the prevalence of children whose sex assigned at birth differs for how they feel themselves to be internally. And I want to also, provide space for kids who are sort of like questioning and really understanding what their sexual orientation and their gender identity are. I think, the beautiful thing about people being more free to express these things is that people get to be who they are. One thing that I think can be hard, though, is that children at increasingly younger ages feel like they need to like know right away and like kind of plant their flag in the sand, say like, this is who I am. And some kids know, and that's great. And there's some kids who are kind of figuring it out and understanding things about themselves. And so that might change a little bit. I think we don't do anyone a service by telling them like, this is the box that you chose and you're never allowed to leave that box. And so, the bigger thing for me is there's a number of children who are figuring themselves out. What is the way that we can create an environment to allow them to do that safely and comfortably and to support them in that process? So let's talk about that a little bit. So what are some barriers to care for queer kids and adults? There's a number. So the first is just availability, right? If someone who is queer wants good dermatologic care, we have to be available somewhere. And so that can be a challenge, right? When we're talking about, maybe more rural areas or areas of the country where there just aren't a high density of dermatologists. If someone is not available to provide that type of care, whether it's, treating acne, whatnot, that's a problem. But beyond being available, it also has to be accessible, right? So if I say, yep, I have my clinic hours and they're from 9 o'clock until 3 p.m. and it's on Monday, Tuesday, Thursday, Friday, and that's it, that's going to be a problem, right? Kids are in school. They'd have to take off from school. Maybe if they're getting themselves there, they have to take a bus. Where I work in Seattle, Seattle Children's Hospital, our main hospital, is actually in a very sort of wealthy area of Seattle. That is not really conducive for folks who, have public aid, where we are the only clinical site that will take all insurances. They have to take a number of modes of transportation to get up to us. Not all families have more than one car. What if a parent is working, right? So these are all things that we would need to make sure that we are providing opportunities for people to, get the care that they need in a way that's not overly burdensome for them to get it. Then we want the care to be acceptable. I can be excellent at treating acne, and if I don't treat you well as a human being because of your gender identity, your sexual orientation, your race, your ethnicity, that's going to be a problem. That is not acceptable care if you feel like your dermatologist is not being respectful for you, not listening to you, not really addressing your concerns. Do we have bathrooms that maybe are unisex, so that, people don't have to decide like, oh gosh, like where is it okay for me to use the restroom, right? There are different ways that we can make our clinic spaces more inviting, and I'll get into that a little bit more, just to make sure that people feel like they are cared for, and that the care that they actually receive is actually acceptable to them. And then we want our care to be equitable, right? Am I providing the same level of care for you regardless of what your insurance status is? What if you have an intersectional identity where you are a racial minority and you also are a sexual or a gender minority, right? Am I taking all these aspects of who you are and what your lived experience is up until the point that I see you into account, right? And you really need to be thinking about all the things that may impact your access to care, your ability to do the, perform the recommendations that I make for you. And so again, really getting down to the granular level, being like, who is this person in front of me? You're not just an assembly of identities, you're someone. And so let me know what your story is a little bit. And I think that's what I hope that everyone can get out of this talk today. And then I think it's important for us to all remember our implicit bias. This is something that I think sometimes people get a little bit anxious talking about. And I just want to say, like, we all have them, okay? I have them. We all marinated in a culture that told us to think about people and to think about populations in a certain way. I grew up in a time, I was born in 1978, in the 80s, where people threw slurs around like gay and fag like it was no big deal. And of course, like as a like young homosexual person, right, like that's going to make it really hard for me to identify who I am. And then this generation sort of like ages, and these things that like we sort of just internalize, right, it's hard to undo those. And we can. Okay. So I don't blame anyone for having a bias, but I do think that we all have to put in the work to say, like, this is something that I learned that's actually not right. And it's also not okay. And so if I'm moving in that direction, I really need to take a step back and say, no, 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 no. Like, this is a person in front of me. They're not just like this label. And what am I going to do to make sure that I'm providing them the best care possible? And, this is more than just sort of like theory from me. This is a study that was done by John Barbieri's group at Harvard, with the Sum of Us database. And what they actually looked at were what people identified as barriers to care if you had an inflammatory skin disease and you identified as a sexual and gender minority person. Now, this is all in adults, but I think it holds, similar messages and learning points for children as well. So what they found is that sexual and gender minority patients were more likely to delay specialist care, mental health care, and filling a prescription because of cost. And the reasons for that is because they had issues with transportation. They found that their healthcare provider was of a different background, including their sexual orientation, gender identities. There may have been some sort of like discrepancies in understanding. And they were also more likely to report not always being treated with respect by their healthcare providers. And on top of that, getting back to this idea of intersectionality, sexual and gender minority patients of minority racial identities were also more likely to experience barriers to care. So again, when there's multiple layers of your identity that are minoritized, it's really important for us as providers to take into account the entirety of the person in front of us and make our best effort that we can to provide them the care that they need. So how are we going to do that? Let's get into some useful tips. So the first one is use inclusive language and follow your patient's lead. There are so many ways of identifying both your sexual orientation and your gender identity. I could give a talk on this, and that alone would take 2 hours. So I'm not going to go into everything, but I do want to just say that, we often like to think about these things as binaries. You're gay, you're straight, you're cis, you're trans, and there's a whole, rainbow of identities that exist between those. And it really behooves us to kind of get a good sense of how someone identifies. I recently had an experience with a patient who actually used a new gender identity that I'd never heard before. He was like, I'm a demi boy. And I was like, I don't know what that is. So can you educate me so that I know how to best take care of you? And he's like, oh yeah, that's what this means. I pride myself on being a doctor who is on top of things. And also when I don't know, like I just asked. And I think that this patient really appreciated that I took that time to learn this like bit about him, and that he could teach me something too. So again, if you don't know, it's totally fine just to ask. Curiosity goes a long way, and I think it's usually seen as very helpful and kind. Common terminology. One thing I do want to identify is that gender identity is independent of transitioning medically. So someone does not need to be, like getting puberty blockers. Someone does not have to have surgery for them to be transgender. What All that requires that that person tells you the way that I feel in my body is inconsistent with the body that I have, and then we just believe them and support them in that way. Just so we're clear, I've used some of these terms already, but transgender men are their sex assigned at birth is female, but they identify as a man. Transgender woman is someone whose sex assigned at birth is male, but they identify as a woman. And then gender diverse or gender queer, again, have a more expansive view of gender. Sometimes it's helpful from a medical standpoint to sort of put people into trans masculine versus trans feminine. This is more helpful just from the context of like what types of hormones might you be interested in receiving to sort of affirm your gender identity, no matter where you fall on that spectrum. It's not meant to like conclusively label, but to be more of an inclusive term that can encompass a lot of things as we think about medical care for these populations. So what are some phrases that we can use? Again, just keeping things really open, not too narrow, a very kind of like expansive use of pronouns and terms. So I just like say, hey, the first time I meet a new patient, I want to make sure you're comfortable. How should I address you? What should I call you? Right? What pronouns do you use? This is a really simple way just to say like, hey, like I want you to know that I understand that, what the way that you experience the world is maybe a little bit different than what we think of as like a default cisgender, heterosexual way of the world. And it's already cluing in the patient to the fact that you want to be an inclusive provider for them. Avoiding gendered, terms for partners and things like that is also helpful. Instead of saying like, hey, do you have a boyfriend or a girlfriend? Do you have a significant other? Who did you bring with you today? Are you in a relationship, right? These are other ways that you can ask that really don't sort of like make assumptions about the person before they even open their mouth and have an opportunity to, tell their story to you. And then in general, just follow your patient's lead, right? They may start and just tell you everything that you need to know. They may be using pronouns to refer to themselves, to their partners, to, the other people who they brought with them, and just kind of going along with that. That's a surefire way to get it right. The most important thing that I can tell you is when in doubt, ask. Again, I think that sometimes as providers, we feel like, oh man, like if I don't know this, like the person's going to think that I like don't know what's going on. They're going to think that I'm insensitive. I have found that like nothing could be further from the truth. Just asking. It demonstrates that you're curious, that you want to get to know the person as a human being instead of just a skin condition in front of you. Excuse me, I've never had someone, get upset with me when I just ask for clarification when I'm trying to get to know them better. Now, I think one of the questions that sort of came up too is that sometimes it can feel very invasive. And I certainly understand that sort of concern as well. And there's good reason for sexual and gender minorities to sometimes like distrust, like, why are you asking me that question? What are you going to do with that information? And so, what I find helpful is to sort of like preface like why I'm doing the question asking, right? So I'll say something like, your goals for your gender affirming care are really important to me because it's going to influence what sort of treatments I can recommend for you. So I'm just going to ask you a few questions because I need to make sure that I'm providing you the best recommendations possible for your care. And I just want to make sure that I get to know you and all things that matter to you so that we're on the same page. And when you put it that way, I think it's very, like it's open. You're just demonstrating to them that you're doing that because you care about them. And that's a nice sort of segue then to get into like, okay, like let me ask you these questions. What are other ways of demonstrating inclusivity? I think it's important to making it a division-wide mission. If each individual on this call, like it tries to be the most inclusive provider, that's awesome. But if you have, a front desk staff, MAs, other providers in your office who are misgendering, who think that this stuff doesn't matter, that's going to still make it really hard for you to like have a practice where, people feel welcome and included. I think, we've made some strides certainly in academic settings around collecting pronoun sexual orientation information for the EMR that sometimes gives you the information that you need. I still think that it's very reasonable to sort of just check in and say, hey, I see that your pronouns listed here are he, him. Are you still using those? Especially I find in the younger groups that I work with, sometimes it changes. And so one visit, they're like, yeah, like he, him is what I want. And the next time it's like, well, like he, they, great. Just let me know and, I can adapt with you. I'm doing this to check in to make sure that I am still addressing you the way that you want to be addressed. I think it's important to acknowledge that family can mean more than just biologic family. I do not want to, add on to the sort of stereotype that every queer child is kicked out of their homes and sort of like, disowned by their family. That does happen at a higher rate for queer children than for cisgender and heterosexual children. And also there's many queer kids that I work with who have loving and enthusiastic families that are there to support them. But I think it's important for us to remember, too, that those of us in the queer community sometimes have what's described as a chosen family. These are the people that understand my experience, that I trust, that I feel comfortable with, that I love. And sometimes those folks may be, in a visit as well. And so you just want to make sure that you know who everyone is in the room. And then you want to maintain privacy, right? Just because that person's there, that doesn't mean that your patient necessarily wants all their medical information related to that person. So just asking like, hey, who do you want to be in the room while we're having, doing the exam, question asking, counseling, right? And just being clear with that with your patients. I think privacy is also really important in this age of telehealth. You never know who else is in that room when you're talking to a patient. So it's really important to say like, hey, are we in a private space where it's just you and me and no one is going to overhear the conversation that we're having? Because what you don't want to do is accidentally like out one of your patients. I think signage can be helpful, rainbow stickers, a non-discrimination policy. Those are really, I think, useful just to sort of give a quick like, hey, this is important to us, this matters, and so we're putting this out. It is not the beginning and the end, okay? It's like the very bare minimum. So you can't put that out there and then like not back it up with the way that you actually treat patients in clinic. But I think can be a helpful way to say like, hey, like we understand that you may have different needs based on your sexual orientation, your gender identity, and we're here to support you. And then sometimes unisex and gender neutral restrooms can just be helpful too. It takes out a lot of the anxiety of like, which restroom am I like allowed to use? Am I supposed to use? It really just kind of takes that out of the equation. What are special considerations for kids and adolescents? In general, kids don't want to go to the doctor anyway. They don't want to tell you anything. They're kind of distrustful of you. And if that is superimposed on a background of, harm because of interactions in the medical setting for someone who has a sexual or gender minority, that's going to worsen health inequities because those kids are not going to want to come back to see you if they feel like every time they see you, they just feel bad about themselves. Privacy is so important for teenagers. Again, this sort of like goes, without saying, it's so important to maintain a child's privacy, and really navigating that between children and their parents can sometimes be tricky, but we can talk about that a little bit. Remember that when your patients are filling out a demographic form, often it's the parent. So the parent may say like cisgender, heterosexual. That doesn't necessarily mean that's the actual story. So it is important to, have some time alone with the child to ask them those questions yourself. And then just remember, too, that there's various stages of coming out. So I've had many of my patients tell me, I think that I'm gay. I haven't told my parents about it yet. Great. It's really important for me to know that, right? And so my first question when someone discloses something about their sexual orientation or gender identity is, who else knows? And who else is it okay for me to share that with? And if they're like, no one else knows right now, I have a plan to like come out to my mom. Great. I try to encourage patients to share, who they are with their parents. Also, if it's not a life or death situation, that's not my place to intervene. But I always let them know, like this is a safe space. I think that, your parents seem really great. If you feel comfortable, I really think you should do that. And I'm here to, support you as well. But you just want to make sure that you don't accidentally out your patients. And then there's a few hills that I'll die on in dermatology, and this is one of them. Subspecialists are really, really, really important in the care of children, and dermatologists especially, right? If I see a patient who's on Accutane, I'm going to be seeing that patient monthly for a good, like 6 to 12 months. If I see someone who has eczema and they're on a biologic or they're on methotrexate, I'm going to see them every few months, right? So more often than not, we are a touch point with the medical system for children or our patients more than their primary care provider is. So, sometimes I hear from dermatology audiences, they're like, I don't know, like this isn't really my thing. I'm not providing the hormones. Like, do I really need to know this? Yes, you absolutely need to know this because every touch point with you is an opportunity to show a patient that they are worthwhile, that they deserve excellent care, and that they are acknowledged for who they are as a human being. And I can't tell you how powerful that is. What it demonstrates to a patient is this is what quality care, this is what being respected looks like. And then when they go somewhere else and they don't get that, they know they don't have to stand for it because they've seen what that care looks like. So please don't underestimate the power that you have. You don't have to be providing the hormones. You don't have to be doing any surgeries or even facial feminization or other cosmetic procedures. You just have to like acknowledge and respect and support the person that's right in front of you. And that will have a profound impact on their lives. I guarantee it. Confidential time. Let's talk about that. So for kids, I usually, have some time alone with them when they're around puberty, around 12 years of age or so. If it's just like, hey, you're seeing me for a war freezing, I don't go into it. But if I have a longitudinal relationship with you, I think it's important for us to have that conversation. So I'll ask the parent to leave. I will say I rarely get pushback on it. They often understand why, but I try to put it in the context of, this is a great opportunity for your child to learn some autonomy. They're not going to be living at home forever. This is an opportunity for them to talk about their healthcare. And then if we have questions, we'll bring you into it. And most parents are down with that, at least in the area where I live. It is important to know that state laws and HIPAA regulate contraception to minors. We can prescribe contraception, especially when we're talking about things like iPledge. But it does vary from state to state whether parents need to be involved in that decision. So you can go to the Guttmacher Institute. That's the link that I have on the bottom, and they actually have the updated information for every state. Things I discuss when we're talking about gender diverse patients: gender identity, what their goals are for gender affirming care, and where in the process they are. It's also important to understand their sexual behavior. So someone can say like, oh, hey, like I'm straight, but if you are having, like homosexual sex, then your risk is different, right? So it doesn't matter what label someone has, it actually matters who they're having sex with. So sometimes you need to get into like the nitty-gritty details, the type of sex that they're having. These can be very uncomfortable conversations for both you and the patient. And also, like, it's just part of healthcare, right? We just want to know what are your risks so that we can counsel and protect you appropriately. And then I'm going to talk a little bit about the psychosocial impacts of acne. So let's get into that. So I got a grant from the SPD and PEDRA to actually look and work with kids and ask them, how does your sexual orientation and gender identity influence how you feel about your skin? And we actually asked that question specifically. And the results that we got were very interesting and changed the way that I practice. So what we heard from cisgender and transgender females was they spoke a lot about their acne and just in general keeping their skin clear. So they said, I feel great pressure to keep my skin clean and clear. How it looks impacts how I feel. If my skin is blotchy, if I have acne, I feel worse about myself. And from a transgender female, women are expected by society to take better care of their appearance than men to fit society's ideal standards, right? So getting back to where we started at the beginning of this talk, right? These kids know what's up. They understand how social expectations work, and unfortunately, that sort of pressure really impacts their mental health as well. They understand there are expectations of them to perform in a certain way, to be quote unquote feminine. And sometimes that's a lot, right? Especially when teenagers have a lot of other things going on in their lives. We also got answers from transgender males, and these were a little bit more varied. Some were just matter of fact. I started using hormones, my acne got worse, so I have to wash my face and use an acne cream now. The second one says, I feel kind of weird buying skincare products because I feel like as a boy, like I shouldn't take care of my bodies or my skin. It's just really hard to think that people aren't judging me. On the flip side, I'm on testosterone and I get a whole lot of acne. And in this way, like it's sort of a rite of passage, right? It's affirming their gender identity because boys and men are supposed to have acne, or it's okay for them to have acne. Okay, so the sort of psychosocial impact can be complicated depending on the person and how they feel about it. These last two talk about, dysphoria. So one says, I don't take as many showers as I should because of dysphoria. I don't always do skincare because it's seen as a traditionally feminine thing and it can make me dysphoric. Okay. So, again, thinking about how we've all been socialized, this idea that women have clear skin, that they're the ones who are, cleaning their face, washing their bodies. It's so ingrained that in these children, just the simple act of showering makes them dysphoric. And so that's an important thing for us to think about too, right? If I'm prescribing you acne medicine, I'm like, here's your Clinda in the morning and here's your tretinoin at night and here's this BP wash to use in the shower. My patient may be like, okay. And then they come back in 4 months and they're like, nothing got better. And I'm like, did you do what I told them to? And they say, nope. And I say, why? And they say, because I don't like washing because it gives me dysphoria, right? These are questions. This completely changed my practice because I don't know whether what I'm recommending is something that the patient will actually do and why they won't do it. So it's really important to ask. The flip side of it too is that sometimes patients come to see you and you're like, yeah, you have acne. You want to treat it? It's important to understand that not everyone who comes to see you wants their acne treated. So there's going to be a population of transgender males who are like, no, like it's cool because this is like quote unquote, like it means I'm a guy. And everyone is going to have a different perspective on their transition, on the side effects from hormone therapy. And it's really important for us to, again, have these conversations with folks that we know where they're coming from and we can support them appropriately. What do you do for the skin exam? Most important thing, just respect people as you would all other patients. I think it's really important to recognize too that, some transgender people might not feel totally comfortable in their bodies. So you want to make sure that you're conveying action before inspecting, certainly before palpating, and then, making sure that you're using the correct terminology or language that the patient uses to refer to their anatomy. And then just being really, thoughtful with the draping. You want to make sure that you're only looking at one, area of the body at a time, and then making sure that the patient feels covered, and, protected in that way. It's been recommended in some consensus recommendations, allowing the patient to have headphones and some music in if that makes them feel more comfortable, right? So you can work with the family and the patient to say, like, how can we make this the most comfortable experience for you possible? Because I think it's really important for us to remember that, a simple skin exam, no matter who you are, is very vulnerable, right? We are standing there naked or in some stage of undress in front of a physician who we might not know very well. So, just keeping that in mind and remembering that, patients are coming to us at a very vulnerable time. And when they have an identity that makes them even more vulnerable, we want to be as thoughtful as possible. Remember that chest binders can be used sometimes in transgender males and gender diverse patients. These are sort of tight bindings that are placed around the trunk in order to reduce the appearance of breast tissue. These can be really, really hard to put on just because they're so tight. So someone might not be super enthusiastic about removing their chest binder during a visit. If it's the first visit, totally cool. Do the best that you can with the skin exam, and then just say, like, hey, maybe we can maybe come back like as my first patient of the day in a few months, and we'll do a more complete exam in this area as well. And then maybe you can put your binder on after, right? There's ways around it that just, respects patients' comfort and their wishes as well. Okay, so let's summarize what we're going to do. So we're going to validate people's identity. We're going to use appropriate pronouns. We're going to educate our staff so everyone's on board with our mission of providing inclusive care. We're going to create a welcoming clinical space. We're going to respect family members and patients' desire for disclosure to others. We're going to maintain patient privacy. We're going to have direct, clear, and honest conversations. We're going to be really prepared to sit in discomfort. And I promise, the first number of times that I started having these conversations, I was like, oh gosh, my heart's beating on my chest. I feel so awkward. And now it's just like another day. It gets it gets easier real quick as long as it's, something that you practice. But really what I'm asking all of you to do is to love the person in front of you. And, sometimes people hear the word love in medical settings. They're like, I think that we are encouraged to just be as sort of bland as possible. Just like, we're just here. I'm the provider. I'm just here to, do this work and give you a diagnosis. So we are care providers. We care for people. And what I'm actually asking you to do is to care about them. And, the love that I'm referring to here is not the sort of hallmarky, saccharine Valentine's Day love. It's a love that the feminist author Bell Hooks describes as the giving of oneself to nurture the growth of somebody else. And that's really what we want to do. And, I'm talking about this in the context of sexual and gender minority patients, but this really applies to everyone that we come across who is a different background or identity than us. I think it's really important that as dermatologists that we are able to take care of anybody who comes into our clinic, regardless of where they came from. And what I mean where I came from, what I mean is what their life experience was up to that point. There's going to be patients I see that have a different sexual orientation, gender identity, race. They may have a condition that is rare, right? It doesn't matter. I want to make sure that they feel cared for and recognized as an individual human being with their unique needs. And that does take time. I'm not going to, make bones about it. It's hard with the pressures that we feel because, medicine is just being turned into another capitalist machine. But I think it's so important for us to do what we can to maintain and nurture these relationships because it makes a difference and our patients get so much better care. And I'll tell you, at the end of a day, I feel good that I can go home and I'm like, I changed someone's life for the better today, even if it was in just a small way. That alone is worth it for me. I have one more tidbit that I'm going to give you. So in the study that I mentioned earlier, where we were talking with adolescents and asking them how they felt that their sexual orientation and gender identity influenced their skin, we also asked them a question: do you prefer a provider who is, straight or queer? And we asked this on a Likert scale, where if you said 50, you really didn't care what the sexual orientation or gender identity of your provider was. 0 was you wanted a cisgender heterosexual provider, and 100 was you want a queer provider. And what you can see from this is that sexual minority patients strongly prefer to have a sexual or gender minority dermatologist. And when we asked by gender identity, transgender males, transgender females, and non-binary folks, again, strongly preferred someone who was queer, whereas heterosexual and cisgender kids just didn't seem to really care one way or the other. And my takeaway from this is, obviously it's great if those of us who identify as queer, can be out in our clinical spaces to our patients. And I think it's also important to recognize that not everyone lives in an area of the country or the world where it's safe to do that. And so it's really not on an individual provider to say, like, I am safe, admitting that I'm gay or transgender or what have you. I feel very lucky that I work in a city and an institution that is very welcoming to people of all types. I have never felt like I couldn't, identify myself as gay to my patients. I think that it's been very powerful for a number of them. Just 2 weeks ago, one of my patients came out of the closet to me, and you could tell his grandma was like, "Yeah, tell him." And she was like, "He was so excited to tell you." And I see him for like a congenital nevus and eczema. This was not something that was part of like a broader sort of like, queer specific medicine. He was just excited to tell me. And I hope that's in part just because I could be a representative of the community and just be like, it's just me, and I'm just a doctor who cares about you, and I happen to be gay. And that really meant a lot to me. And the reason why I say this is because I think it's really incumbent not on just us as individuals, but on the communities, the departments, the divisions, the practices that we have to create spaces that allow providers to be who they are. And I'm going to just take a step back. You might remember this photo from the beginning of the talk where I told you I was gay. This photo actually was taken just a few months after I came out of the closet. For those of you who don't know me, I moved to Seattle about 11 years ago. My work at Seattle Children's is my only job that I've had since fellowship. And about 3 months after I moved here with my wife and my children and my dog, and I bought a house, I came out of the closet. And as you might imagine, that was a time of just a lot of upheaval for me. And I was really worried how people were going to perceive me at work. And what I actually discovered or, experienced was that everyone here just wanted to support me. And that started with Rob Sidbury, who I mentioned early in the year, but all my colleagues at Seattle Children's, all my colleagues in the broader UW community, they said, we're sorry that you're going through this, and we are here to help you. And, because of that, that gave me the confidence to be who I am and really sort of nurture that interest in being a provider who gave back to his community. And every step along the way, when I said, I think that I'm going to pivot my career and do this now, everyone's like, great, go and do it. And, to be quite frank, I wouldn't be here today if I didn't have that love and that support from my entire community of, co-faculty, the residents that I trained. Everyone was just so supportive of me. They understand that I was finding myself. And I guess I'm wearing this shirt today. I didn't do it on purpose. I don't know if you can see it. It says, "You are not too old and it is not too late." And I think that's true for all of us as we figure out who we are and what our purpose of our lives is. And as it relates to like this whole, working with people of, different gender identities, we were not trained with to have this knowledge when we were trainees, for those of us who are older. And it doesn't matter. It's not too late to say, like, this still matters. And I'm going to learn and I'm going to immerse myself in this so that I can be the best provider possible. And so I really appreciate you being with me here today. The coda to all of this is because of support and love that I felt from all the people here. I'm really happy. I remarried a few years ago. This is my husband on our wedding day. These are my boys who have, grown up with a gay dad and have loved me and accepted me, every step of the way. They're now in high school. And I just want to let you all know that it feels really good to fight and do right for others and to really stand up for what you believe in, even when it feels hard to do that. So I encourage you to bring these lessons not just to sexual and gender minorities, but to all the populations that you serve that might need a little extra love, a little extra help, because you can make a difference in their lives. And I hope that you learned a few tips today, and I really appreciate you being here with me. So thank you. And I'm happy to take questions.
Thank you so much for this amazing. Oh, Thank you so much, Dr. Boos, for this amazing and super helpful and inspiring talk. This was awesome. We have a lot of questions, actually, a lot of interest about treating acne
Yeah.
in patients transitioning So maybe can we spend a few moments talking about that? Some questions are, what are the best treatments for a trans male with cystic acne and depression? How do you navigate hormonal acne, in a patient who's transitioning, etc.?
Yeah. So let's kind of start from basics. So all topicals and oral antibiotics are appropriate to use like regardless of someone's gender identity. So you don't have to worry like too much about that. But systemics, when we're talking about oral medications, does matter. So sort of counterintuitively, if you have a transgender male, giving them a combined oral contraceptive, so like a progestin estrogen combo, is a very reasonable thing to do. Number one, it serves as a birth control if you need it for iPledge, and it does not interfere with the masculinization process. I will tell you, there's no studies that I'm aware of in the medical literature looking at, the use of a COC to treat acne specifically in transgender populations. Anecdotally, to me, I'm just kind of like, it really should make a difference because there's so much testosterone in the system that like kind of pulling it out a little bit with like increased sex hormone binding globulin and like all the downstream effects of estrogens, like it should make a difference. But I have a number of colleagues in the gender clinic that I work with here that like it really worked well. So I think it's something that you can always offer. I will tell you that most patients don't want to do it because they're I'm a man. I'm not taking a feminine hormone, right? And so that can be a hard thing to navigate, but just to let you know, it is an option. For transgender females, spironolactone is a very reasonable thing to give them as well. It's just important to know that that may be a part of their transitioning regimen already. So they may be getting like that as part of their gender affirming hormones. So if it's already being provided by their gender care provider, you don't want to like add on top of that. You can talk about maybe like changing the dose a little bit, but that's something that I would do, again, like with the sort of knowledge and collaboration with their person providing the hormones. I will tell you, I love Accutane. I love isotretinoin for it's mostly like transgender males who I see who need it for their acne. At any one time, I'd say like I have like 4 or 5 kids that are on it who are transgender, and it's amazing. And I guess I want to talk about like the depression thing a little bit, right? So it is true that sexual and gender minority children have higher rates of depression, suicidality, like anxiety, mental health issues than cisgender heterosexual children. And not all of them do, right? So it is something that's important to ask about. You can use like a PHQ-2 or PHQ-9 in your clinic to ask about those things. What I do is I just have like a really, like honest conversation with them. Just like, hey, most people who get on this medicine, their skin gets better, they feel better about themselves because of it. We have all this data that kind of shows that. And my interpretation of all these recent meta-analyses that have come out is that people who have pre-existing, sort of like depression or, suicidality are probably more increased to develop this like idiosyncratic reaction to the Accutane. But I think it's just really important to be like really clear about like what the goal is and why you're worried, and maybe not like oversell that, but to say like, I'm asking because of this. And if you've had this history in the past, that doesn't mean I'm not going to give it to you, but it's really, really important that you tell me because, and this is the phrase I always use, you are more important to me than your skin. Having clear skin is not worth losing your life to me. And so I need you to understand that about me. And, again, I feel really lucky because 95% of the time I'm working with a child whose parents are very like enthusiastic about it too. And they're like on board and they're like, yeah, like they'll tell me everything. Like it's totally fine. And like, I'm another set of eyes. And so, I think that, we can still do this without having these irrational fears that something bad is going to happen. I gave a child who was kicked out of school because he had homicidal ideation is what he was accused of. I was like, tell me more about what happened there. And he's like, well, here's the story. I was like, okay, I'm not actually worried about you, but no one else would be willing to give him isotretinoin, and I did, and he did great, and his skin cleared, and he was super happy, right? So I think just having those like very frank and like thorough conversations is sufficient.
That's so helpful. Thank you. And your talk has generated so many questions. If you're okay with it, I know we don't have a lot of time, but maybe
Yeah,
we could kind of compile everything and send it
yeah,
to you. And then if
I'm
you're
happy to do
willing
that.
to answer
Yes,
some of them, okay,
yes.
awesome. And I just want to say also, there's so many comments about how inspirational and amazing this talk was. So
Oh,
thank you.
thank you. I really
Absolutely.
appreciate it. My other hill that I'll die on in medicine and in dermatology in general is that, we all have to be ourselves. And I appreciate that I can come here and just kind of like be myself. but it's too exhausting to be any other way. So, everyone who's out here, whether you're an established dermatologist or a trainee, being you makes a difference, and you're going to have those patients that see themselves reflected in you, and it matters. It really does. And I've also sort of resigned myself to the fact that like I'm not everyone's cup of tea, but I'm most people's cup of tea. And if they don't want to come back to see me, they don't have to. Like it's cool. Like it's fine, right? And so I find that things
That's
get a
such
lot
a good
better when you
point.
can just be yourself. So, so thank you.
That's and such good advice, so useful for all of us in medicine. So
Yes.
thank you so much, Dr. Boos. Thank you for giving
Yeah.
this
Sorry
talk.
that
We
I talked so
really,
much. I
really
didn't have enough time
enjoyed
to
it.
do the questions, but I'm happy to answer those. So
No, it's fantastic. We wish it was longer. We might have to have you back for another session.
sounds good. Sounds good.
All
Thanks
right,
for the
thank
invitation. It
you,
was nice spending the hour with you all.
and thank you everyone for attending. Have a great night.